Okay, awesome. All right, good morning, everybody. Today we're going to be having Trish Caldwell, our Senior VP of Clinical Operations. She has led several webinars this year. She is the pioneer of our PBHU, all of our webinars that we've been doing, our whole education program. So she has changed the entire clinical programming at all of our facilities at Promises. So if you've taken a webinar with Trish before, I'm sure that's why you're back. And if you're new, welcome. This is going to be a great presentation today, and we're really glad you all are here. To introduce Trish just a little bit more um, professionally, Trish has been in the behavioral health field for 27 years. She is committed to providing clinical and operational excellence through program development that is really dedicated to supporting outcomes. So Trish focuses on clinical quality using evidence-based practices that align to a trauma-informed approach to treatment. She's a licensed clinician, marriage and family therapist, and is certified in both co-occurring disorders and substance abuse. Additionally, she has been an adjunct professor for the last 16 years and is currently teaching for Drexel University's Master's in Family Therapy program. She is trained in DBT and has specialized in facilitating multifamily DBT groups for teens with ADHD, trauma, and substance use disorders. Additionally, Trish has created the first young offenders treatment program in Delaware County, serving first-time offenders with drug charges. A regular speaker at both national and regional conferences, Trish specializes in adolescent behaviors, behavioral health, ADHD, trauma-informed care, family systems, and first responders. Welcome back, Trish. Always good to have you. Let's go ahead and move on. Yeah, so the CE process for a lot of you that are attending to get those CEs for the end of the year, you are here. That means that you are already signed in. Having that sign in, having that registration today, that's kind of acts as your sign-in sheet. So if you're here, that's perfect. Now make sure that to receive credit, you can only miss about 5 to 8 minutes of the presentation. So please stay through to the end to make sure you get your full credit. Make sure as well that you're only using one device per person. So if you and a coworker are sharing a computer, that doesn't work. So make sure, again, you being here on your device is your sign-in sheet. So if you're sharing and you don't need a CE credit, that's fine. But if you do need your CE credit, make sure you have your own laptop, cell phone, iPad, anything like that. It just needs to be one person per device. After the training, you'll receive an email from JotForm with a survey. So to fill out the survey, you just log in and then you'll just be prompted to fill out the survey. And then as soon as you fill out that survey, it kicks back the certificate to you right away. So if you wait 24 hours and you're still not seeing that certificate come through, just email me and it might have just gotten lost in the ether. So, and I will have to close that survey next Friday. So especially with the holidays next week, be sure you go ahead and just fill that survey out today. I will get it to you within the next hour. If you're not seeing it, you'll either get an email from me within the next hour or so that says, like, here is your survey, or in the next probably 2 to 3 hours, you'll receive an email that says you did not meet the requirement. A lot of you that are here right now are going to receive the you've met the requirement email, but so either way, you hear from me, and if you don't hear from me today, that email may have gotten lost in the ether again. So just send me an email that you're waiting for it. Wait till the end of the day, and I'll get back to you on Monday, usually with the answering those questions. So again, just know that I have to close the survey next Friday. And then other slides and resources from Trish will come out next week. I'll send a recap email with this recording and other resources. Okay, so during the webinar, you'll see you have a chat box and then there's also a Q&A box. So the chat box, you can reach out to me with any technical questions, CE questions, those kinds of things. Save the Q&A for questions just for Trish regarding content. I just want to make sure we keep those separate so I don't lose any of those important questions. So Q&A is for Trish, chat box is for me. Trish is going to take a 5-minute break and she'll come back and answer some of those first initial questions that come in. And at the very end, we'll answer the rest of those questions. That's it. Oh, and then next training, we have one more training, you all. So in December, Wendy is back. If you had taken one of Wendy's trainings earlier this year, she's one of our family services directors. And she'll be coming back to talk about the power of family and connection recovery. So if you're a marriage and family therapist, this is one you'll definitely want to attend. And that's going to be on December 20th. I will drop that registration link in the chat box in just a moment. Okay, Trish, I'll pass this one over to you.
Thank you. Thank you. All right. Good morning, everybody. I appreciate you being here on a Friday, certainly a Friday right before the holidays. Um, I want to well, one thing I'm going to say. So if you have not yet attended a webinar with Wendy, I highly recommend that you do that. Um, Particularly during the holidays. We know that the holidays are incredibly stressful for those that we are working with and their families, right? Nobody recovers alone. And so this is a great time to be able to really understand. So how do we utilize the power of connection to help our loved ones, and those that we are serving to navigate this recovery process? Holidays are incredibly difficult in the behavioral health space for everyone involved, and being able to connect them to others, being able to connect them to their own recovery, is a critical component to this. So I highly recommend that, particularly as the holidays are coming up, and Wendy's fantastic. So just a little plug for that, because I think that's a topic that we could see more and more and more, just as we continue to understand how individuals heal, and how families heal themselves. So I do want to start with giving everybody a little bit of information about who we are as Promises and where we are. So I know that we have a lot of registrations from across the country, which is super exciting, but it's always important for me to highlight some of the areas that we are currently serving. So I am in the state of Pennsylvania, not too far from the Ranch of Pennsylvania. That these are all of our sites. I'm really proud of the work that we've been doing, which is continuing to expand so that we offer a full continuum. So as we know and we understand the research that continues to come out, that we want to be able to engage our patients, in meaningful, sustainable recovery, and that full continuum has been linked to greater success. So we have the Ranch of Pennsylvania. We also have inpatient, and a full continuum in the Ranch of Tennessee. We have our Georgia location, which is a PHP and boarding, and IOP, and we are excited about the potential of opening up an inpatient. We have Florida, outside of Daytona, that has a PHP and boarding and an IOP, as well as a full residential treatment facility. In the state of Massachusetts, we are located, and we have 4 in the state of Texas. So really continuing to advocate for services for those that need access to care. I say this all the time. I am a trauma-informed provider. And so in the same way that I liked to look at the colleges that my daughter were going to and applying to, I highly encourage you that if you are working with somebody and they need access to care or a higher level of care, I highly recommend that you pull up our website, look through so you can see our facilities. So the horses is at our Rancho Tennessee facility. The picture that looks like there's a fireplace, which there isn't. At least not in that picture, is the Ranch of Pennsylvania, which is a beautiful property. We have Brazos on the bottom, and Houston on the left. And so it's incredibly important from a trauma-informed perspective to help an individual to see where they're going to live, right? So that's a home away from home for a little bit of time as they navigate their recovery. And so really being able to pull that up and share that information can be incredibly helpful in managing and helping to mitigate some of the anxiety associated with that next step. I encourage you to do the same thing for the families who are also going to have to engage in what can be incredibly difficult. So these are all of our locations across the country, and I encourage you to take a peek at that. So I am going to start. So if you've ever had a training with me, you know that I don't go over the objectives because the objectives are everything that I go over. But I do want to start with this topic. So I've been a therapist for a very long time, right? And so I've serviced in different areas and worked in long-term residential treatment facilities for adolescents. I've worked in inpatients and outpatients, and partial care hospitalizations. So I have certainly run through what behavioral health looks like. What is inconsistent in behavioral health is treatment. And so the point of this training, and so I'm grateful for everybody that's on today. I think that as we, as a facility, certainly it promises, but we in the larger context of what behavioral health looks like, I think we are at a time where it's going to become incredibly important for us to start reflecting on the work that we're providing and ask ourselves the questions. How do I know if this is working? Right? We certainly know that the information that our patients are sharing with us, so they're telling us we like it, we're telling us that they think that it's helpful, they're sharing with us their feelings. But how do we know if something is truly working? We continue to have conversations within this field that we understand this as a brain disease, right, or a disease of the brain. We understand addiction and mental health um, within the foundation of the impact that it has on the brain. We understand the science behind it, and yet behavioral health is still really trying to catch up on utilizing scientific data to determine if our patients are really getting well. For me, this is so critically important because this is one of the only diseases that bears with it a tremendous amount of shame. This is one of the diseases that, or chronic illnesses, however you want to frame that. But this is one of the only ones that when it doesn't work, the individuals typically internalize that. And they say, there must be something wrong with me. I must be broken because we haven't really provided them data to show if they're improving or if they're not. We haven't really been able to provide a measure of what is and isn't working. And we haven't really tied what is or isn't working into things that always align to them. So I really am, again, grateful that all of you are on here today. I hope that what you do is walk away today with a little bit of understanding. It's going to challenge you a little bit. So if you are a therapist, welcome. I am also a therapist. And so this can feel a little bit uncomfortable sometimes. But we're all doing this for the same exact reason. We all show up for our jobs every single day because we believe in the possibility of hope, because we believe in the possibility of recovery, and because we believe in the possibility of individuals being able to transform their lives. If we didn't think that, we're in the wrong field. But today is a day for us to start challenging ourselves and saying, should we be more aligned to what best practices are? Should we be more aligned to what the medical field does in order to identify what are best practices in measuring how our patients are doing? So I'm going to gently encourage you to think about this in a little bit different of a way. If you have questions, please feel free to put those into the no, I don't remember where Callie said. I think the Q&A box, right, for me. So please feel free to put those in there. This really is that important of a conversation for us to have today. So I'm hoping that this is as meaningful to you as I think that it's going to be for your patients. So where are we today? So the current state of behavioral health treatment. So here is what we know. Treatment is oftentimes focused on facility-based care. How do we know that from what we hear? Because we oftentimes hear our patients saying, that's the only place that I feel safe. You're the only person that's going to help me to manage my recovery. And again, when I use the word recovery, it's from whatever you're recovering from. So it can be mental health, it can substance use, right? So that's behavioral health. And so it's oftentimes also tied to a person. So as a therapist, oftentimes we would hear things of like, Trish is the only one that I want to be able to talk to. Trish is the only one that I trust. And so I'm going to challenge that a little bit as we go through that. But that's where we're seeing treatment. It's facility based, meaning if I go to one facility, I get a certain type of treatment that's normally dictated by the therapist. But if I go to another treatment facility, with or within your own network, that person is getting a completely different treatment. So I'm going to pull this back again to highlight if this was a medical condition, there might be slight differences, and we'll talk about that, right? What are the best evidence-based practices? So, but if you were to go to a medical provider and you had hypertension, you had heart disease, right? You had cancer, you had anything. There are best practices that it shouldn't matter where you go, that you can rely on, that you're going to get that. In behavioral health today, we can't say that with full confidence because somebody could go to one treatment facility and maybe they're getting a lot of process-oriented clinical care. You might go somewhere else and they're doing some relapse prevention, but then somebody's doing kind of like self-esteem and self-confidence or self-confidence. Then you're going somewhere else and maybe they're doing mindfulness, but maybe they're not. And then you go somewhere else and they're integrating, right? So treatment becomes then about the facility, less the transferable skills of the individual, which we'll talk about. It is oftentimes not continuous. So if you happen to be working in an inpatient, where we see is a struggle where our patients are stepping down to that next level of care. So the way that I always look at it is, imagine if you're an inpatient, you're mostly looking at yourself as like an ER, right? You're going to take something that's some conditions and an individual that are struggling with some acuity, and you are going to manage those high risks that an individual is struggling with so that they can continue on their journey. If you're in the ER, you're attending to a broken, collarbone, a broken leg, and you might also notice that there's hypertension, that there's heart disease, that somebody has diabetes. And so when that person leaves, you're saying, listen, we treated this, but this is the importance of the follow-up care for you. So you do really need to see a physical therapist. You do need to see a primary care physician. You do need to see, a specialist in diabetes. And what we see is greater rates of response. Patients do, right? They go to an ER, they understand that that's what they're supposed to do. They're triaging them and they're making sure that they are safe enough to be able to go to the next level of care. In behavioral health, we're seeing a struggle in that area. We're seeing patients coming into treatment, spending somewhere between 20 to 30 days in an inpatient, and then saying they no longer need any treatment at all. But the outcomes of that individual, what we're seeing time and time again, is that those individuals are a statistically much higher likelihood of having to readmit. So if we really look at this as a chronic illness of the brain, which we can argue, right? So we've got enough research to say that that's what it is. Then we have to be able to change the way that we're communicating this with our individuals and our patients and their families so that they understand the importance of the ongoing. This is where, again, from Promises, I'm proud that we're continuing to move into having that full continuum, because we know that when there is continuous treatment, patients improve their outcomes. That when we look at it, diagnoses is oftentimes not precise or patient-centered, which I'm going to get to. Treatment planning and the delivery is also not precise or patient-centered. So how do we know that? Because the diagnoses just kind of come in. Oftentimes they just get stuck with an individual and they come in, right? Sometimes we've got patients that have 10 diagnoses. That the treatment plan in behavioral health is oftentimes relatively generic. Relapse prevention, patient needs to attend groups, right? Patient needs to, and so there's nothing that really says, what about Trish is she working on? When we start to integrate measure-based care, which I'm going to be talking about, obviously, that's why you're here, we're going to talk about how that ties directly into that treatment plan and how that is actually patient-centered. Because when I have a treatment plan, and again, no shame in this game. This is why we're all here, right? I've been a therapist. There's plenty of treatment plans that I had that were basically just generic treatment plans. And I was like, Trisha's treatment plan looks the same as John's treatment plan, which looks the same as Heidi's treatment plan, right? And I just moved some things around. I might have put something in a quote because this was how I was learning to do this. But today we have an opportunity to really say, you know what would make Trish's so precise? What is Trish struggling with? That's just really about Trish, and how do we measure her progress so that she can see if she is or isn't progressing? That's patient-centered. And that what we know is that care doesn't oftentimes adequately support families, other caretakers, or address social determinants. And so those are critical elements. So if we look at some of the driving forces to long-term sustainable recovery, which is what we're all really here for, no matter where we are within that, right? If we're practicing physicians, right? It doesn't matter if we're in the ER, in a private practice, or in a specialty program, we're all invested in the same thing. So whether you're inpatient, outpatient, PHP, we're all invested in the same thing, which is our patients' overall long-term sustainable recovery. How often are we involving our families? Because what we know, according to research, is that when families are involved, there's a higher rate of success. When you address the social determinants of an individual, so health equity, when those are addressed, that shows more promising outcomes than some of these other things. If you have a patient that's worried about housing and we're doing process-oriented treatment, they're not going to get well because the priority of what they're thinking of is where am I going to live? So addressing those health disparities, the social determinants of health, if they need childcare, helping them to be able to access childcare is going to be really critical for them to be able to continue their recovery journey. When we talk about standardization, so again, I've been with Promises for just about 2 years at this point, came in very specifically to change up some of our clinical offerings, right? And what that meant was that we were going to align to best practices. We were going to engage in measure-based care because what I was invested in, which the organization was invested in, was being able to improve our patients' outcomes. And so one thing that we did is we standardized our clinical care. And so when we talk about what does that mean, and again, that's going to be a huge critical component to the measured-based care because I can't measure something that's not standardized, right? Nobody can measure that. So when we're looking at it, standardization is the enactment of care activities designed to promote uniformity, stability, which is trauma-informed, right? And integrates professional thought, meaning, actions, and ties it to the outcomes. So if our patients are learning, and that's really the premise of what evidence-based practice is, it's the consistent, repeatable experience that allows you to identify, is this working for that individual? If everybody is doing something different in every single group, in every single patient experience, then how do we know what's working for the patient? And more importantly, how does the patient know? If I don't know as a patient what's working for me, other than every time I go to see this person, I start to feel better, but we, facility-wide, human-wise, right, as a therapist, I can't be a coping skill for an individual. So standardization allows for us to look at what is working, and then the repeatable experiences allows for us to measure it. So standardization in the field of psychology is the process of making a test uniform and setting it to a specific standard. Now, some of you might be on this call right now as therapists and saying, no, I'm not doing that. So I'm going to just encourage you to just sit tight and keep listening because it doesn't take away your creativity. It doesn't take away who you are in relationship with your patient. It really can have the opportunity to strengthen it because now you're working on a goal that you can each see if it's working or not, and then you can adjust accordingly. So if you're sitting here right now saying, there is no shot I am going to standardize the way that I provide care to my patient, I'm going to ask you to just gently keep your mind open and see if something that you learned today would help you to challenge that a little bit, right? Help you to be able to standardize the experience so that we are really doing what's in the best interest of the patient. And that standardization involves the administrating and scoring of a test. This is another one that if you're like, I'm not giving assessments, I'm going to encourage you to just stay put and let's have that conversation, right? In the same manner for everyone that takes it. That's a critical component. So then just at the very basics of like, so what is measure-based care, right? We hear it all the time. There's a lot of catchy phrases that happen all the time in behavioral health. I will say this isn't a catchy phrase. This has been around for a long time. It's just that people aren't doing it. So I will say it that way. Measure-based care is not a catchphrase. This isn't something that people were like, this is brand new. It's been around for a very long time. It's just that people aren't doing it, right? And we'll talk a little bit about where that is. So at the core of what it is, measure-based care is an evidence-based practice in which individuals routinely complete standardized measures throughout treatment to help monitor the clinical progress and inform your clinical decisions. So it means that every time I meet with a patient, I provide them an assessment tool. If I'm working with a patient and an inpatient, I actually might start using some of those assessment tools when I notice that there's higher rates of dysregulation for a patient. So if I'm just using globally, which we all know, right, some of the patient pain points. So waiting in line for their medication is always a pain point for a patient. Making phone calls to their families is always a dysregulating, not always, right? So let's not say that, but can be very dysregulating for our patients. All normal, all appropriate. That would be a great place to be able to measure, right? So if I did something, and we'll talk about some of the measured tools, but that would be a great opportunity to say to the patient, you know what? Every time that you anticipate those phone calls, your anxiety goes from a 14 to an 18. This is going to be what our target area is. And so as I go through this, I want you to just start kind of calibrating like and thinking how this works. Because imagine the power of that for an individual who doesn't know why, right? It's just I'm afraid of my family, but I love my family and I don't want them to not be involved in my life. But like, I get so anxious and then I engage in these behaviors, and so avoidance occurs. That's just natural behaviors, right? We've been hardwired to avoid things that make things worse for us. But the messaging can get lost in our brains in the way that it communicates. So when you think it from a human perspective and patient, if I'm like, listen, let's start measuring the anxiety each time before you have these phone calls. And let's start building some of these skills to provide you some opportunity to get re-regulated before you have that phone call. And then next week, let's do it again and see if it's working. If it is working, that patient in that moment is not like, I don't know why I mean, it's just easier for me to make a phone call. I don't know why. That patient is like, you know why I'm able to make that phone call? Because these are the things that I've done, which is the skills, which we'll talk about. That is very different than when the patients are like, I don't know what's different, right? This time I'm going to try harder. I'm going to just, now I'm getting along with my family. Things don't happen like that. These are actionable. And so that shifts it. So when we're talking about, and this is why that standardization becomes incredibly important, is that it is a step-by-step approach for assessing, treating, and then reviewing those outcomes. And if things are working, then you're able to say, these are some of the things that are working. So you got to put those in your tool belt, right? Like these are really helpful for you. They seem to be very directly linked. So when you're not with me, you don't need to have access to me because you have the skills that you know are helping you to manage your anxiety. When we look at if it isn't, so if I reassess somebody and their anxiety is still the same level, I'm not like, I don't know what to do with you, right? I'm like, okay, so these skills are not working effectively for you. So we won't get rid of them altogether. We'll come back to them, but they're not working in these moments. So let's try this instead, and let's see if this helps. Do you see how patient-centered that is? That is all about Trish. That isn't just a random relapse prevention or we want you to practice a mindfulness, right? Like these are the behaviors that you're struggling with in this moment. This is what your score is saying to you. And these are some of the practices that we want you to start engaging in to see if it helps to improve. Man, that's so empowering for a person, right? And for a therapist, that feels terrific, right? When you're able to see that the patient is doing it other than the patient just saying, I feel better, right? So it provides you the insight into the treatment progress, highlights the ongoing treatment targets. So again, when we go back to the treatment planning being a little bit more generic oftentimes, sometimes we don't have goals that are actual goals for that person. We're like, you need to attend 5 groups a week. You need to attend, you need to have one family session. You need to identify 5 relapse prevention plans, but there's nothing really actionable for that. I mean, they have to attend group, but they're supposed to anyway. So when you have this and you're able to provide treatment progress and you're like, listen, you've been hovering about an 18 to a 20 on the GAD-7. These are some things that we want to work on. So I'm going to have on your treatment plan that we're going to reduce that by 8. And then these are the things that we're going to work on to do that. That's very different. When you tie it to, we're going to reduce your anxiety associated with managing your phone calls, or you've been seeing nursing 5 times a week for PRN medications, that might be a little bit of a concern for us, like something's going on for you. So let's figure out that. Then it's specific behaviors that I am struggling with that you are tying to what my score is. And then you're tying it to the skills for me to improve my behaviors. And improve meaning I'm lowering my scores and I'm not engaging in behaviors that I would later regret. So here's a question that has come up a lot. And so it felt like it warranted at least an acknowledgement of like, okay, let's have a little bit of a conversation because what I hear a lot of people say is that we do this, right? We've been doing this in our organization for a long time. And I'm like, that's fantastic, right? I love everything about that. And I'm like, so tell me how you're doing it. And they'll say, well, we provide the GAD-7, the PHQ-9, right? The PCL, whatever it is that they are using. We use it at the beginning at admissions, and then we use it before they discharge. And so those are actually outcomes. That is not measure-based care. So highlighting that difference becomes actually really important for us as a distinguishing. So I'll go through this, but I always say it, and in our teams as well, outcomes are for us, right? As providers, outcomes are for us. We want to see, is this working or not? But the outcome, the patient's leaving. That's when we just did it, right? So it's at admission, that's your baseline, and then it's a discharge. So the patient's already leaving. There's nothing we can do to intervene. They left. We're just looking at like, did they get better? Right? So important, but not measured-based care. So the difference between those two is basically lying in the focus and the approach of the delivery. So measured-based care, you're seeing, is throughout the course of treatment. Every single week, every time I see that patient, I'm doing an assessment because they will be patient reported, right? So again, the GAD-7, the PHQ-9, they are going to, we're testing that. And the emphasis of measured-based care is in the monitoring and the tracking because it's driving your treatment approach. So let me say that again. When I'm doing measured-based care, I'm using this to measure the care that I'm providing. So I use the tools and then I use the information to say, should we go this way? Should we continue to do what we've been doing because it's been working? Or this isn't working at all and we need to pivot a little bit because we want to be able to see how to manage those scores different. But it's every week. When we get to like, so why are we not doing measure-based care collectively in behavioral health? We're going to come back to that. Outcomes is the end result of care. So behavioral health oftentimes does outcomes, right? They're like, patient came into treatment in this, patient left treatment and they were this way. And so while again, that's incredibly important, it's not sufficient in patient care because what didn't happen with outcomes, the patient has no idea why they improved. Because we did an assessment when they came in and then a discharge, we did it again. We don't even tell the patient if they've gotten better, right? Maybe we do. We're like, you're better, right? That's why you're discharging. But the patient doesn't know why because they don't know what was going on week over week. Equally as important for those of you that are having to work with, providers and health insurance and value-based contracting, the payers are also like, they should get better. Right? So we're not looking at that they get better just in your care. That's not long-term, sustainable, meaningful recovery. Payers are saying we actually want them to get better long-term. So you just measuring the outcomes, you're saying our patients have improved in their depression scores, right? So 50% of our patients have improved in their depression by 50%. Payers are like, they should, right? They came in a crisis and they left 20 to 30 days later, they should be improving. So measured-based care is that we know that mental health and substance use is not a linear process. It has ebbs and flows. Patients get highly distressed and then they can get re-regulated. Patients can feel incredibly depressed and then get re-regulated. It's not they start here and you end here. That's not any of us. So this is a little bit of the change. So outcomes you're still going to need to do. Outcomes are showing, is our patient improving? But we want long-term meaningful recovery. So we need to see what was working week over week when they were the most distressed. That's measure-based care, right? So the measure-based care is the method of monitoring the progress, while outcomes are just the result. That's the difference. Measure-based care is for your patients, outcomes are for us. When we look at, so again, another question that has been confusing, and I feel like I apologize, all these therapists, right? You're probably like, I just want to talk about like something processing. But these are so important for us to really understand these differences so that we really can be more intentional with the interventions with our patients. So measured-based care is a core element of evidence-based practice, but it's not the evidence-based practice, right? It's in partnership. So measured-based care is the routine monitoring. The evidence-based practices is using practices that have demonstrated that when there is a standardization and it is repeated, that there's evidence to suggest that those work. So when we think of like evidence-based practices, you're thinking of, again, DBT, CBT. Those are evidence-based practices that this is what I'm supposed to do. It's a consistent, repeatable experience, and we measure whether those improve our patients' outcomes. Measurement-based care is more accurate and patient-centered by approach. So I'm going to go back to, so why do we do this? Why are we in this field? Because we believe in the possibility of hope, because we believe in the possibility of recovery, and because we want to be a part of the journey of somebody else's recovery. So then when we start looking at measure-based care being more accurate and more patient-centered, that feels like that's the ticket, right? So when we're systematically giving a patient a brief validated system assessment, before or during every visit. And so these are just the two biggest ones, right? So the GAD-7 is the one that is monitoring anxiety, and the PHQ-9 is monitoring depression, right? That when you manage these week over week, that we see progress. So having the patient and the provider review the data together. So it does feel different, right? So when a patient comes in, and sometimes I'll hear that, right? Therapists are like, it doesn't feel like I'm doing therapy because we're kind of reviewing data. And I'm like, but I mean, that's what medical providers do, right? They're still providing medical services, but they're also going over your results. They're also highlighting what is and isn't working with you. So we want to collaborate on both of those things, right? And so being able to review it together to say, all right, let's see what it is, right? That becomes a critical component to this. Then using that evaluation, trends, right, relative to prior assessments, right? That in this session, we can update the treatment plan. This is how the treatment plan becomes individualized. So right in that session, we're saying, okay, so here's where you are today. So let's add this to your treatment plan, because you know what I'm curious about? This seems to still be a struggle for you. Like at night, that seems to be your hardest place. Your urges are strongest at night. It seems like where you've had the most difficulty with like managing your own regulation. So why don't we add that to your treatment plan, and let's do an assessment in there. And then let's see if these skills work. So in your head, right, you can send them through the chat box and I can look, or the Q&A, right? Give an example of a problem that can be measured in your treatment space. So I'm not going to pause to do it, but if you send them through, then I'll have Callie send them, because I want to be able to acknowledge, like, yes, that's exactly right. Right. So if you are listening right now, think of an individual you are currently working with and a problem that you could put on their treatment plan, that you could measure, that you think is tied to anxiety, depression, trauma, right? So, and then how we measure it. So throw those in the chat box or the QA. Callie, I forgot. I'm sorry. I forgot which one. But throw those in there so I can highlight. So as I'm kind of going through this, I'll look at some of the responses and then share them with their larger group, right? So that we are like, so this, I could do this on the treatment plan. And I'll give an example towards the end, but I want to hear from you on what's a problem that you could help the patient address in these moments, that you could utilize an assessment that would be able to help to track if this is working or not. Not relapse prevention, because how do we track that? Not saying that I wouldn't do it, but I can't track relapse prevention because in a lot of ways, treatment is the prevention, right? We're providing you a UDS. I can't track that. But could I track where they are struggling the most with the urges, right? So it seems like it's the evening that the urges are the most difficult for you. So that could be tied to the anxiety, the depression, right? Those could be tied to those racing thoughts that we can measure, right? Different. Using measure-based care can highlight when it might be time for a patient to switch medications. It can be time to change the dosing, right? So how collaborative. So when we talk about the needs for the collaboration of teams, how perfect is to say, like, listen, Trisha's been working on these skills week over week. She's still struggling with anxiety. Her score was an 18. This week she was like an 18 again. And she's engaging in these skills and she's taking her medication as prescribed. I might send her back to the provider and say, I'm not sure if what you're prescribing right now is working because she's doing the work and it's still not helping. Rather than just saying, she's saying that she doesn't feel better, so we're going to send her back to the provider. And then we're just, right? So it just helps to streamline very specific interventions to help a patient. And that's part of the coordination of the care. Now you all have concrete information to say, this might be, right? Patient is doing these things, but what we're noticing is that at night, she's not sleeping through the night anymore. So I wonder if we need to adjust the dosing. I'm not a medical provider, so I'm not suggesting and I'm not telling a doctor what they should or shouldn't prescribe, but wouldn't that be valuable information as a doctor that I'm saying these are the things that we've done. These are the measures that we continue to provide her, and we're not seeing improvement. That's different. So here's where research continues to say traditional care, which is you come in, you do patient-centered treatment, like patient focused, right? Where we process, we say, what do we want to talk about today, right? Those kind of things. Or we just do whatever crisis comes into the door that day, right? Which is oftentimes what happens, versus measure-based care. Here's what research continues to highlight. Measure-based care outperforms traditional care. It is associated with a decrease in our costs, which means a decrease to the cost of our patients, which is critically important for them, right? Because this is expensive for them and takes them out of work and takes them, right? All of these other things. And it reduces the likelihood of deterioration. Compared to traditional care, measure-based care has shown the following. It improves their health outcomes, period. That it monitors symptom reduction with those that have psychiatric conditions. So it helps to monitor the symptom reduction. It improves role functioning, satisfaction with their care, because when the patients feel like I now know why I do what I do, and now instead of doing that, I know I can do this instead. I now know it was my anxiety that was keeping me from calling my family. It wasn't that I don't want to ever talk to my family again because I know that I love them, but I'm so stressed about this relationship because it's been so conflicted. It's my anxiety. So like if I can help to like manage my anxiety and then I can have a productive phone call, that connection is huge. It enhances the therapeutic relationship because they know now that you're working. So I would love a doctor that had great bedside manner. I would love it if a doctor was delightful to talk to and, you know, I could sit down and have a conversation. But I'll actually like and respect more the doctor that's showing whether or not I'm improving. That's a difference. So I now like my doctor, this one, because that one is being very clear with what we're working on and if I'm improving. So it does enhance the relationship, right? It improves the accuracy of your clinical judgment. So instead of just being like, stop doing this, you're really tying it to like, hey, these are the things that are going on. These are some things that I want you to do because this is really where we want you to go. Your baseline should be closer to here because when you're here, those behaviors don't seem to happen. If we want to talk about it clinically, we can talk about it as the window of tolerance, right? We want to get the patients back into their window of tolerance. So when they go too high or too low, and those are where they engage in the behaviors, we're getting them back here. This is really tying that in. So again, if you're wanting to like use therapeutic language, that's okay. So then you're just telling the patient, we're just going to keep trying to get you back into that window. Here's your window. And sometimes your anxiety goes into hyperarousal and you're like, ooh, oh, those are the behaviors up here. So like, let's look at these skills to get you back down here and let's measure to make sure it worked. So you can use clinical languaging, right? You don't have to keep saying like, I want to do measure-based care with you. You can, I do, but you don't have to. You can use languaging like window of tolerance. You can use language like regulation. You can use language of like your depression is here and we want to move it here. That's all fine. And then it helps the individualized treatment planning, right? So that's that piece. When we're looking at feasibility to implement on a larger scale, this is then when you have, so instead of having like one therapist that seems to be making a difference in the patient, now you are organizationally able to say, we should all of our patients, no matter who their therapist is, no matter where they're getting treatment, all of our patients should be getting some level of a standardized care. Makes sense. So here's something that's important. Because sometimes what will happen is that therapists will say, like, I think my patients prefer to just have talk therapy. And so I'm a fan of choice. Choice is always a critical component. It is also a part of trauma-informed care. But are they informed? Or do they just think that just talking is going to make them better? Because what I know about patients that I've worked with for the last 27 years is they just want to feel better. And if they think that just feeling better is going to come from just talking each time that they see it, then that's what gets reinforced. If I think that if I go to the doctor's office, me just showing up is going to make me feel better, then I'm just going to keep showing up. But when they've spoken to patients in treatments that integrate measured-based care report experiencing a higher level of engagement, which means they show up. Because when they stop showing up, you can measure that, right? I can be like, hey, what is going on? Because for the last 2 days, you have missed group. So something's going on with you. And instead of making them have to figure out why, because again, in their recovery, sometimes they don't know why. They don't know that they're feeling anxious. They don't know that it's the depression that's been getting in their way. And so that default of like just going back to the avoidance, that makes sense. So when I don't have to ask why, and I'm like, listen, let's do this. Let's do one of these assessments because I'm worried that maybe your anxiety is just feeling like it's difficult to manage. That would make sense, right? Like post-acute, or you're like early in recovery and you just got home. I'm imagining that it's got to be difficult being at home with, responsibilities and all these things. Let's just measure some of the anxiety. And let's just focus in on that. Let's get some skills to focus in on the anxiety. And let's see if that helps because it's got to be really difficult for you to get into group. Gosh, if you're feeling so overwhelmed with that. Now I'm not trying to get them to do that. I'm actually trying to get them what they want, which is to feel better, right? So that's where they have the higher level of respect because I'm not trying to coerce them. I'm not trying to be like, you got to do this. If you don't come to group anymore, you're going to get discharged. If you don't do this, you're not going to. I'm like, something's getting in your way. And we got to figure what that is. So like, let's see where you are because here's the thing for our patients. When they say they feel better in anxiety, if their baseline was a 24 and now they're at a 22, they do feel better, but they're not in their window of tolerance. They're still way outside of it. So when we don't measure it, and we'll talk about, so what if it doesn't, there's inconsistency. But when we don't measure it, we don't have a way to have that kind of conversation because they're like, I do feel better. So when I have the conversation and I'm like, listen, I appreciate that you're feeling a little bit better, but a 22 is pretty high still. So we want to look at that. We want to figure out, should we be doing that? And how do we get that a little bit lower? And then let's see if we get that lower and you're still not coming to group, like let's have a conversation about that. That changes it. So that's from a patient's perspective, higher rates of engagement and a higher level of respect. So here's something that I tracked before, right? So again, promises, we standardized our curriculum. We provide measured-based care, right? It is what we are doing because we are invested in long-term, meaningful, sustainable recovery for our patients and their long-term outcomes. So here's an interesting piece. So when we first started to do this, our patients started, so after maybe 3 weeks, our patients started saying, we miss talking about, whatever we talk about. We miss some of the groups. Now, when I say the patients, it's typically 2 or 3, right? Because other patients are enjoying kind of the way. But there's always a couple of people that were communicating a lot in group. And so they probably do feel the difference. So the site shared that with me. Hey, some of the patients are feeling like they want to go back to the way that things were. And I was like, okay, so let's pay attention to what's going on. And I'm like, let's look at their attendance. So what we found, so we know that when patients engage in treatment at higher rates, that they have higher rates of success. So prior to us launching this, their patients had a lower attendance in groups, while the patients were simultaneously saying, I miss talking about these things in group, they were attending in the mid 90s to group. So that actually matters to me. So I hear the patients. So I'm like, the patients they're just telling you that they're feeling a change. Validate that, acknowledge that, but we're not changing it because your patients are showing up, because your patients' outcomes are improving. That matters. So we can sometimes, and so the way that I said it to our teams, that I will say here, sometimes we want things that aren't good for us. Sometimes the patients want something because it's what they've always been used to, and it's because they've thought that that's what was going to make them better, but it doesn't. So what I like to say to my teams, I love donuts, but they are not good for me. But I love them, and if I was given an option between donuts and fruit, I'm always going to choose the donuts, but it doesn't mean that they're good for me. That's a little bit of the shift. So here's the why. I'm going to go through this slide pretty quickly. So here's the why behind it, because it provides routine monitoring. Screening alone does nothing to provide or improve outcomes. Screening alone does nothing to improve outcomes. It is when you have a system in place for routine monitoring that then drives your clinical interventions. That's the game changer, because it's person-centered, because nobody else can have my scores. Nobody else can have the exact things that you're working on because I'm just me and I'm struggling with this. Everybody can have a relapse prevention plan, but if it's not tied to my score, then it's not as person-centered. Because it is whole person, that when we're looking at the wholeness of an individual, it allows for us to highlight those discrepancies. So this is what was brought up to me once when I did this before. Well, what if the patient says that they're fine, but their score is an 18? Or more, the reverse, right? The patient underreports their score, right? These are self-reported. But you're looking at this individual that you're like, you've been struggling with sleep at night. You're saying that you are having a hard time going to group, but you scored like a 7. So let's go through this again because something's off. Because would it be normal for a patient to not know how to accurately represent like what they're feeling? Yes. Would it be normal that a patient is like, I don't feel like doing the screening again, so check, 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 check? Yes. But when you can tie it back into the importance of the way that they are able to navigate their recovery, they're going to reinvest in it. So if I have somebody that I'm like, man, you're a 7. So I wonder what that is, because like you're going to like PRN for medications, you're still struggling with groups. I might say, you know what? I wonder if, did you just take your meds? Because what sometimes will happen is our patients will take their blood pressure medication and that will reduce their anxiety right after. So two things happen there that I go, all right, so like I'm gonna reassess you like in another 2 hours, right? Let's see how you do in group and then we'll reassess. The other piece is I'm gonna say, do you know that when you take your blood pressure medication, your anxiety goes down? So here, when you get discharged, what I've noticed is that in the past, you don't always take your medication as prescribed. But this one's actually tied to that. So did you know that? I'm telling you right now, most patients don't. But now it's tied to it. So you can, right? That I'm like, that's why we want to make sure that when we discharge you from whatever level of care you're discharging, that's why you need to follow up with your primary care physician. Because if you stop taking your blood pressure medication, it is going to impact your anxiety. And we already know that the anxiety is really what's at the root of, your substance use, your engagement of self-harm, whatever the behavior is, right? So that ties it directly in. And sometimes that score is the way that I'm able to figure that out, right? That I'm like, at night, they're like struggling. So like, how did this happen? And then I'm like, did you just take your meds? Because that'll work, right? That'll help. Or maybe they practiced the skill, right? And it actually worked in the moment, right? Those are how you have actual clinical conversations that are specific to the person. And then the timely feedback. If you're not giving them timely feedback, then they're not going to retain it. That's why it has to be every week, right? So research indicates that asynchronous feedback is ineffective. So if you're not doing it, if you're like, oh, well, you got that, and I think that you're better, like if you're not giving consistent feedback, it's ineffective. So if they only did it every 3 months, so if you're in the outpatient and you're like, well, we do it every few months, if they're doing it every 3 months, they did not improve. Why? Because it's too much time to improve a behavior or to engage in something different. I'm going to do 2 more slides and then we'll take a 5-minute break. So measure-based care improves our outcomes, right? So there's the piece two. So measure-based care, outcomes. Measure-based care will improve our outcomes because it monitors and it makes the biggest difference for patients who are not responding as expected. So instead of telling a patient that they're patient resistant, instead of not engaging in something, the measured-based care is able to say, this didn't work the way that we thought. That could be a medication, that could be your clinical interventions, it can be both. But something's off because at this point, I would have expected that you would have been lower on this assessment tool. We're not worried about it, but it's going to drive interventions in the same way that if I have hypertension or high blood pressure and they do something for me to lower my blood pressure and they're like, it's still high. They're not like, oh my God, Trish, like you're never going to get any better. They're like, okay, we got to adjust the way that we're treating you. That's it. Yeah, it didn't work. So we're going to try something different. How often are we saying that to our patients? We're not saying it didn't work. We're like, I don't know. Maybe the patient's not ready, right? Language of not of recovery. All right, so I do have a question. Are you doing one measurement at a time? For example, if a client is suffering with anxiety and depression symptoms, do you choose to measure one for a period and then when it improves? I do them both. Yeah. So those are the two biggest. There's other ones if you're really looking at it. So if you have ADHD, you can monitor ADHD symptoms and stuff like that. But when we're looking at behavioral health, and particularly when we're looking co-occurring, right? Depression and anxiety are the two that have been most linked to improvement, right? So we know even with post-acute, but anxiety and depression seem to be the most universally used. But there are other assessment tools that you could use. Um, but I would be using them simultaneously. And then we're going to know, right? So if the patient isn't really struggling with depression, then it's a consistent. But can a patient 2 weeks later become incredibly depressed? Sure. And then if I see that, I'm not alarmed because those are human emotions that are going to continue to happen for that patient throughout their lives. But I'm like, oh, this week was a different one. Your depression score is lower or higher, right? Depending on how you're looking at it. I wonder what's going on. And then it's a conversation of like, tell me a few things that might have changed that contribute to that. Are you sleeping? Right? Your anxiety is also high. So could that be contributing? Are you worried about what's going to happen next? Are you worried about your job? Right? All these things. And again, I don't have to process this to be able to say. So like, let's do some of these things to help to get that. So both. Confronted with graphical evidence that their patient is not making the expected progress, therapists are more likely to modify treatment. Right? So here's an interesting study, right? So research that was done showed that sometimes therapists have a strong tendency to overestimate client improvement. For anybody that's ever worked with me before, you hear me say this all the time. This field requires so much humility on our part, right? We are always having to research. We are always having to stay up to date with current trends, right? We are in the field of human beings and we are constantly learning. But we got to be humble that sometimes we got to figure out, is this working or not? And that the tendency is that we make assumptions that they are improving when they're not. That's a humbling statement. If I'm tracking it, it's going to help to guide me because there's no shame in my game either. I'm like doing the best that I can as a therapist. And how else would I know if I'm not measuring it? Right? So our patients who care about us too will sometimes say, yeah, this is helping. I feel better. But they're not. Right? So we can struggle to recognize patients who plateau, meaning like, ooh, I think you're ready for that next level of care or worsen. And what we sometimes hear is that when a patient worsens, we act like it's their fault, like something's happened to them, or, they don't care anymore, or they just, they want to use, or they're just not ready, right? Like we change the narrative all of a sudden, as opposed to just being like, oh gosh, yeah, something's going on. And it could be physiological, right? There could be circumstances, discharge planning can be stressful, all of those things. So it takes it from being personal for either side and highlights we got to do some of these changes, right? So that is a huge difference. And so another study that found that patients who responded poorly to treatment, those whose therapists were monitoring their patients had better outcome. So when we are tracking it, because it helps to drive me too, I can't become complacent. I can't just be like, I don't know, what do we want to talk about today? Right? Because I'm like, hey, something's not working. How do I know? Because it's right here. So like we got to have a different conversation about what we want to do differently. That is so much more direct and clear from a human perspective. So this is where we'll take our 5-minute break. So it is 11:05 Eastern time. Hop back on at 11:10. If there are any other questions, please send those now. And then when we start back up, I will answer those. All right. So let's get started for the last leg of our training. We had another question that came through, or a couple of questions that came through, but I also wanted to just circle back when I had said, like, so what could we monitor for a patient that came in there? There was some great information, right? So identifying some of their triggers and their cravings. Right. So again, because they can't control the craving, right? Like that, there's certain things that happen for our patients that they don't have control over, right? So I had somebody that had asked me once, like, when am I going to stop having thoughts of like suicidality? I'm like, I don't have the answer to that, right? But that's not what recovery is. Um, so if they don't know, because they're not going to know every single identified trigger for a craving, but can they start to acknowledge like the whole idea of like recognize? Can they start to recognize some of the things that increase the likelihood? And so, yeah, you can start identifying like where do you seem to have those moments, right? Where does it seem to be the worst? Is it in the morning? Is it in the afternoon? Is it in the evening? Right? And then we can tie it to like, are you feeling more depressed in the evenings? Are you feeling more anxious, right? Is there if you're doing the PCL, right, which is for trauma, like you can start identifying some of those things. So that's terrific, right? Indecisiveness is another great one, right? So what is indecisiveness? So they're asking for your help, but then they're saying that they don't want to do anything. So that's a great opportunity to utilize this of saying like, yeah, that's got to be so frustrating for you. Like here you are sitting with me, you clearly want this, but like what's preventing you? So that's another great one. Like that's a great thing to have on your treatment plan, right? Where we're thinking like you have to have this and this and this, but like indecisiveness, yeah. Anxiety in social settings, another terrific one. So I'm not going to be with you when you're in the social setting, but could we monitor it before you go out there? So like when let's start having a conversation about what it's going to be like. So you show up and you're in a mall. What is it like? Where's your anxiety? And I can measure that then to then start to help them, right? So unless you're doing exposure therapy, in which case you're able to do it with them. So there was another person that had highlight that they use the PHQ-9 and they do graphs. And what they were able to say, so kudos to you, I think it was Danielle, um, might have been Daniel, so I apologize. I can't really see because I'm looking at one of the screens. Um, that it led to solution focused discussions about what would be the next appropriate step. So that's fantastic. That's exactly right. Right? All of a sudden you're having conversations about solution focused interventions that that person can do themselves. What we don't want in this field is for patients to use us as a skill because we are not transferable. Our patients have to learn transferable skills that they get to keep to be able to manage their lives in a way that is meaningful to them. So, question, what do you do if the client does not want to complete the screening? I become curious. Like, what's going on that you don't want to complete the screening? Right? So I'm not going to force anybody into it, right? That's the whole thing. I worked with adolescents. I know better than to kind of challenge that thought, but I'm going to be curious enough. And I'm also going to engage in a behavior that helps them to understand the importance of what we're trying to do. So typically, why do I see that patients don't want to do it? They're like, it doesn't, it's stupid. It's not helpful to me, right? I don't want to do it. It's a waste of time. And so that's my job to really help them to make sure that they understand that reason why. Because if they think it's stupid, then it means that I'm doing something that they're not seeing the value. And I need to better understand that. And I need to do a better job of explaining why I want to do these things. Because typically what I have found is when patients understand the why behind something and they feel like it could be meaningful, they do it. It's like, signing releases of information for families, right? A different topic for a different day, but it's the same thing. Somebody says, I'm not going to sign a release of information to my family. I'm like, this feels like it's going to get in our way of work. So it would be the same for that. I'm not angry at it, but I'm definitely curious about it. And there might be some takeaways that I have to do differently. Um, Some therapists have voiced concerns about measure-based care taking too long when administering within the session. Thoughts on how to best administrate it. So they should be short. So I'm not sure what's taking so long because they're really minutes long each. So if they feel like it's taking too long, I think that that might be a supervision moment of saying like, what's taking too long? Is it the patient that's struggling with it? Is it, the therapist and the way that they're having a conversation? But it should take a little bit of time and then it's going to drive your clinical intervention. So Sometimes it's also, what are you trying to get to? Right? So are you like that? I've had some conversations with individuals that they were like, well, I wasn't able to get to this work. And I'm like, but is that work more important than this work? Right? So like you're trying to get to something that they might not be ready to do, right? Like particularly, you talk about trauma, right? Everybody wants to do the narrative, but maybe they don't need the narrative if like today, what they really need is to alleviate some of their depression so that they can get up in the morning. Like today, maybe they need to alleviate some of the anxiety so that they can go to the social outing that they've been avoiding, but that their family's really expecting them to want to be at, right? So it does keep the interventions, right? And to that comment earlier, right? It becomes solution focused. So it shouldn't take too much time that you're not doing what you're supposed to do in that session. Let me say it that way. All right, so measuring the interventions. So this is what I like to say, right? So what measure-based care really is. So I keep referencing this in regard to like medical interventions, but imagine going to your primary care doctor's office for high blood pressure. And you come in and your doctor says, "How's your blood pressure, Trish?" And I say, "Better." And she or he says, "That's terrific. Do you want to talk about it?" And I go, "Sure." And they were like, "Well, what do you think's contributing to your blood pressure?" And I say, "Well, I've been having like this and this and this and this." And they were like, "All right, well, I'm glad that it's getting better." And I'm like, "Thanks, me too." And I leave. What do we actually not know if my blood pressure is actually better? I can say that it feels better because maybe it is better from where it was. I can talk about why I think it's high. I can talk about what's been bothering me. I can talk about what I've been doing. But unless somebody actually measures it, I don't know if I'm getting better. This is behavioral health. So we do need to look at it this way, right? So instead of just taking a patient's word for it, not because they're not telling us the truth, but because they're giving us their experiences and we're not measuring it to see if it matches what's actually happening for them. So I might be saying my blood pressure feels better, but unless somebody says it is or it isn't, I don't know. So that's really what measured based care is, right? Because if my blood pressure, I say it feels better, and then they take my blood pressure and they were like, "Trish, it is not any better. We got to change some things up for you," right? We need to do some pharmacological changes. We need to do some diet changes. We need to do the health changes. We need to do all these things. That becomes incredibly important. So here are the mechanisms of action. So again, you're going to engage the patient. Finds completing measures helpful to communicate their experiences. So I can do that and the measures while I'm in session, right? So if you want the patients to do that beforehand, and that's a part of your way of doing it, right? It is self-reported. Okay. You can also do it in the session. These are minutes long. This isn't like the ASI, right? The Addiction Severity Index, where it's like 60 questions. No, they're short, right? With graphs, it's even more exciting because then the patient can literally see their progress or the areas where they need to focus in a little bit more. That information, so what the clinician notices drives questions for the session. So this ties back in. Yes, I 100% use the BAM. So if you are in, and we'll get to that, if you are working in the addiction field, you should 100% be using the BAM. Um, that not only to track that, but we need to be tracking protective and risk factors. And that is critical piece to the BAM. But when we're looking at it, so the clinician notices, drives the questions for the session. So this is how you tie it in. So how come I'm not able to get to it? It feels like it's consuming it. I'm literally tying it directly into the session, right? Notices a need for action, right? So it signals to me like, things are working. So like, hey, let's go after what's been working because those are your transferable skills. So something's been working because we're seeing an improvement or a lack of response. And I'm saying, something's changed. Right? And I'm now able to say, like, do we need to change the skills that we're providing you? Do we need to make pharmacological changes? Like, what do we need to do differently? Or was this just the circumstances of events? Because if you just had a loss of somebody or something terrible just happened and your depression is worse today, I go, that would be normal, right? That's circumstantial. Like that's part of what just happened in your life. Let's see what happens next week, right? Like normal human emotions are a part of human behavior. So sometimes I just started a new job. My anxiety's really high. I'm like, it sure is. Yeah, that makes sense. So I don't know if I necessarily have to treat that yet. But you're right. You felt it and I see it. That's fantastic. I mean, we can talk about some of these things, but like that's a normal human experience. You started something new. It's driving my session, right? Then the feedback brings the voice of the client into the aspects of the clinical workforce. So then we take action. I address the feedback right inside that session. So when we're talking about like, how do I get all this stuff done in the session? What I'm saying is that some of your sessions might change. It might feel a little bit different because we're monitoring it, right? And so we're not just doing like the whole, like just talk therapy, right? Talk psychotherapy. We're really driving some of those interventions. And so it can feel different, right? So that's where we got to go. Like, so what is it that I'm trying to do with this patient versus what am I actually doing with this patient? Shows the feedback and supervision and treatment team. So again, if you're looking for collaboration, hey, I mean, I had a wonderful person that I've been very good friends with and have worked collaboratively with. And I was working with a patient that had a lot of trauma, and I was struggling with his progress, right? I'm a therapist, and I was like, oh, this is so slow. Um, and this gave a lot of information because I was really focusing in on where I thought that he should be by the time that I was doing what I was doing. And she was like, can you just like slow down for a second? Because look at what you're missing. Look what he's doing. Look where his score is. Slow down because you're both running, but you're in sneakers and he's still running. It's just not as fast. So that was a really important moment for me to swallow that humility and kind of say, you know what, you're right, because I'm missing things. I'll elaborate on the BAM. Yeah, some people are asking for the BAM. I'll elaborate on that. So baseline. So when we're doing this, we have to kind of ask ourselves these questions. What outcomes do you want to track? So based on where you're working, what outcomes do you think need to be tracked? Is it depression? Is it anxiety? Is it ADHD? So the BAM is the Brief Addiction Monitoring Index, right? So it monitors, it has a large scale. You can Google it, right? So the BAM, and there's the BAM IOP, and it does either a 30-day or a 7-day window. Here's what I will say about the BAM. People get frustrated with it because it keeps asking the same questions in regard to usage. So if you're like in an outpatient, right? If you're in an inpatient, it becomes more frustrating, except those protective and risk factors are so critical, right? I like to call that's the recovery capital. I do want to track that. I want to track it so bad that I basically put it on our recovery skills plan. Right. So at our organization, that's on their recovery skills plan that I'm asking those patients to update every single week. What are your protective factors and what are your risk factors? Because if we don't have enough protective factors, then the increase of a reoccurrence is likely, right? And oftentimes our patients are trying to leave treatment and they have a lot of risk factors and very little protective factors. So the BAM does either a 30-day or a 7-day window. Well, they'll say over the last 7 days, and they go through some of the substance use, the urges, right? They will look at the support systems. They're going to look at their connection to community. They're going to look at their connection to work, right? So they are looking at those risk and protective factors in addition to the risk and protective factors associated with their use. So I know that this is for those of you that have done it, that it becomes a frustrating one, but I really want you to like challenge the thought and like say, what is it that I need to figure out, right? Go back to the very beginning where we talked about health disparities and equity and social determinants. Some of the most profound impacts on our patients' recovery are those social determinants. So, and that BAM really does highlight that. Those risk and protective factors are throughout that BAM. So again, you can search it, BAM, IOP, BAM 7. But that's what you need to decide. What do I want to assess? Right? Because I'm going to commit myself to something and then I'm going to have that baseline, right? So that's what I'm doing. So do you have access to the data? So is it in your EMR? That's great if it is, right? That is a lot easier. If it's not, then are you just going to produce it and how are you going to upload it into the chart? Who's responsible for it? So this is a tricky one because everybody's like, well, I don't have time to do it. Well, I don't want to do it, right? Some people are like, well, this person does it at admissions and then this person does it. So that's going to affect your patient's scores. So if I have one person that's doing it here, and then I have another person that does the same thing, but they do it differently, and then another person, because then are we doing it for the patient? If it's not driving our treatment, then I don't need you to do it. Right? I mean, you can do it for your outcomes, just to say it did, here it is, we have outcomes. But it really is supposed to drive treatment. So if I have all these different people doing it, it's not driving treatment. It's just another checkbox. And we all know we don't need any more checkboxes. So it should be meaningful. So that's where I would say, who is responsible for doing this? Oftentimes it's going to be the therapist because we want to be able to utilize those in the session while we're working with the patient to drive, right? That's the whole mechanism. For us, right? So we hire and we have, so I work with a collaborative team where I have, quality and compliance. So we track this. We track our outcomes every single month, right? So you want to have somebody that's really looking at it. If you're an organization, you want somebody that's going to be looking at this organizationally. And then from a site perspective, you want the therapist to be looking at it, right? Are our patients improving? If I have 10 patients on my caseload, I want to look, is my patient improving each week? And I'm going to keep doing that to be able to do that. But if you're in a larger organization, who's going to be tracking this for the organization to see, is this working kind of organizationally? And then how to measure. So here are some of the ones. So this, I know a lot of people are like, what are the ones that you do? These are the ones that we do, right? Again, there's others. You can do other ones, right? The WHO is another one. So there's a lot of different assessments, but it needs to be a standardized assessment that has been validated. So this is how you identify evidence-based assessments to use, provide training and support to the staff. So I have a wonderful team that provides training to our staff on how to do these, right, assessment tools, why we're doing these assessment tools, and what's the benefit for the patient. Because that's going to be the most important piece, right? So why are we doing this for the patients? When the patient's getting frustrated and saying, why do I have to do this? Do we know how to answer them? Because I don't want to do something that the patient doesn't feel is of value. Just don't. So determine the frequency of the assessments, right? So the pre, the post, the weekly, right? And then document those assessments and their results. It should be in the treatment plan. It should be in the treatment notes, right? So that we're doing this. For those of you that work with utilization review, this is another great opportunity to be able to utilize your documentation to successfully advocate for your patients because you're actually tracking that, right? So this gives you another arm to be able to do that. And then how to use the results in your sessions, involve the individual in the analysis, be compassionately curious. I wonder what's going on. So where do we think that this is happening, right? Is it in the evenings? That seems to be, I'm noticing that you're going to see nursing every afternoon, like something's going on for you. You miss your meds in the morning. So are you having a hard time getting up in the morning? Because then in the afternoon, you're looking for a PRN, right? Like, so you become compassionately curious because I'm actually worried about what's happening in the moments more than what happened 15 years ago and more than what they're about to do in 30 days because I fundamentally believe that competence builds confidence, and our patients need to be able to build competence in their day to day. So if you're in the outpatient, the same is true. What are the things that are actively getting in their way? Let's go after those things first because the hardest thing to really manage is that hardest thing. So here's the $1 million question. So if we know it works, then why don't we use it? So this would be, oh, EMR is the electronic medical records. My apologies. Um, so I'm not going to make all of you answer that question, but for a second, I think if we were to ask ourselves, so like, why do we think we don't use it? If we know it works, and we got research over again and again and again and again that's saying like it works, it outperforms regular treatment time and time again, yet 20% of providers are doing it. And the answer is simple, because we don't like change. Because we've been taught to do things differently. And this is a new approach. It's not new, right? It's just catching more because there's more and more data to show and suggest the evidence. That's really it. It's our own resistance to change. And so if I'm uncomfortable with the change, our patients will be. So if I don't understand why I'm doing this, then I'm not going to be able to relay that to the patient in a way that's meaningful to them. But it really is just the resistance to change. We know that this works. We know that this improves our patients' outcomes. We know that it improves their ability to feel confident in their own treatment, which is ultimately what we are here to do. One, some research has also said because the self-reporting can be inconsistent, right? A patient, and we talked about that, a patient can report, like underreport what they're feeling. But isn't that a great clinical opportunity to have a conversation of like, huh, this is an interesting thing, right? You are scoring a 7, but like not sleeping through the night and you're not going to the grocery store anymore. So like, let's have another conversation. So I don't know if I think that that's a reason that we don't use it. I think that that might be another reason why we don't want to use it, right? And so this is where I'm going to encourage again, a little bit of humility on all of our parts. Why are we doing this? Do we do therapy for us or for them? Because if it's for them, wouldn't they want to be able to see if they're improving or not? As a human being on this call, don't you want to see when things are working for you or not? Don't you want to know if your blood pressure is getting better based on the interventions? If you're going to the gym, don't you want to see that you're improving? That's the difference. Behavioral health hasn't done that. And so we're used to it. So this is change, and change is hard. So here's the implementation. So encourage the clinicians. Again, there's a lot of training behind that. I'm grateful that there's as many of you on here as there are, even if you just start thinking about it, right? Even if you just start thinking, like, do I want to do this, right? If you're not right, if you're not quite ready, but you're like, I'm at least curious, I'll take it, right? Because I think we want to be a part of a field that continues to grow and challenge ourselves in a way that allows for us to move closer and closer to improving our patients' outcomes. That's what we're supposed to do. So that's what we want to be able to do, right? So when we're looking at implementation, encourage clinicians to use measures in clinical care decisions. Measures should have the following, like this is what it should look like. Establish a reliable and valid, right? So those ones that I showed you, those are reliable and valid. We're allowed to use those, right? They hit the the requirements of like this is an assessment that has validity. User-friendly and a reflection of what clinicians do in clinical settings. If you don't work with ADHD, do not do ADHD. If you don't work with substance use, don't do the BAM, right? So, like, you want to use the assessment tools that are going to be appropriate to the work you are actively trying to do. So, if you are like, I do talk about anxiety and depression, but I've never done an assessment, do it. Try it. Give it a shot, right? Like, what could be the harm? Because then it starts to give you some really concrete information that it is brief. So when somebody is saying like it takes up the whole session, then that's where I would say, so I mean, I would be curious as to like, where is it getting held up? Is the patient not able to read the information accurately? Is the patient struggling with what to do with it? Sometimes our patients don't understand the questions, right? So they can read them, but they don't understand them. And so if you find that, then you do them, right? I can read off the questions because then I can actually drive it right into my treatment interventions. So it should be brief. It should take no more than 2 to 3 minutes to complete. That's the reality. I don't want 30 minutes. I'm not doing the ASI, right? So addiction severity index. I'm not doing that for every single patient every single time, right? That's time consuming. But these are brief. These are little interventions that allow for us to be able to see what's going on and improve the patient's willingness to participate. If it's taking them 30 minutes, they're like, what am I doing? Because I can't even address the 30 minutes, right? So again, where it becomes meaningful is if you remember the mechanism, right? I'm using these tools and then I'm literally driving it into the interventions that I'm like, hey, what's going on here, right? Right in the moment so the patient can feel it right then. Like, and again, I apologize that I didn't write the right name down, but using that PHQ-9, the solution focus was happening right in there, right in the session. That's fantastic. That it's clinically meaningful and useful, covering the criteria and the symptom domains of the disorder. That's what we're looking to relieve, right? We can't relieve things that are kind of up here for a patient. Sometimes I think our patients think that we're going to absolve them of all feelings. We're not. Like, we're humans. So we're really looking at those symptoms that are getting in your way. It's okay to feel sad. Is it getting in your way? It's okay to have an urge. Are you acting on it? It's okay to want to use. Are you doing it? So like there's nothing magical about any of this. This isn't to get rid of things. It's to help you manage them and to be precise in where you run the highest risk, where your brain will supersede your thought process and you will engage in a behavior that you will later regret. That's really what we're trying to do for a human. How long will I have thoughts of wanting to engage in suicidality? I don't know. Good news is that that's not where recovery is. You don't have to know. You just have to be able to know where those risk factors are, how to recognize when you are triggered by things, how to regulate, and then let's see if these things work. Right? So it's clinically relevant to the decision making. It is easily extractable and not embedded in the progress note, right? So it's in the treatment plan. And then it's sensitive to those changes by medication and therapy. So then why skills? Right? So you keep hearing me talk about skills. And the reason that we want to talk about skills is again, that there's a lot of research. So part of what we understand with recovery, which is fantastic, that when we look at what recovery is, training optimizes the brain areas and the neural pathways involved in performing new tasks. That's essentially what we're trying to do in recovery, right? Here's what you found. Your brain has found solutions in substance use and the experience of what you're doing in isolation and self-harm, right? And what we're trying to do is change that. So the individual's performance on that task improves by new skills. So engaging clients in activities that promote neurogenesis, right? So for those of you that have ever done a training with me, you know that I do love the brain because we're not arguing the brain, right? This is just facts, right? Exercise, we know, changes the brain. Low frequency activities like sleeping and resting or mindfulness, if somebody's able to do mindfulness, changes the physiology of the brain. Learning new skills changes the learning of the brain. So when we provide patients skills, they are changing the brain. But if we only do it every once in a while because we're not doing anything standardized, then there's no changing occurring in the brain. One and done. No, that's not how that works, right? So the standardization changes the brain by learning new skills. So when we talk about, so what is that, right? So learning in that piece, right? So environments saturated with novelty, focused attention, and challenges are vital in promoting neuroplasticity. So hopefully most of us know what that is. I don't want to be too sciencey on this call, right? Because I really just want you to be able to pick up an assessment and start it. That's my goal. But it's helpful so if you're sitting here right now being like, why do I got to do that? I just want to talk about people's feelings, right? I just want to be able to talk. And again, patients have choice, so that's fine, right? If somebody was like, listen, that's all I want to do. I just want to be able to vent somewhere. It feels good to vent. It does sometimes, not most, but not for the highly dysregulated patients, right? So we do need to know where our interventions are. So if you're in an inpatient, it's really not appropriate at all. But what we've found and what research has found is that those environments, so that hippocampus, the part of the brain that retains memories, that's linked to behaviors associated to what most of the time gets a patient in an inpatient level of care. That neuroplasticity says that when patients engage in learning new things, it changes their brain. Practicing a new skill under the right conditions can change hundreds of millions of neural connections. This process of new neurons in the hippocampus, that plasticity is important for our learning, for the memory, and for regulation. This is so exciting, right? So you see, like, isn't that exciting? Like, this is where, like, that hope is. So hope is more to me than just being like, I hope this works out for you. Hope is like, there's hope. This can work. You can get better. Doesn't mean everybody does. No, just like cancer, not everybody is able to do that. But best practices say this is your best chance to getting there. That's this. That's so exciting that we can say, listen, when you do these skills and when we measure this and we can move you, God, this can change things. It's not just like, I don't know what's going to get me better. This is. It's going to change your brain. We need you to sustain treatment in longer term. The full continuum is so critically important. This our patients should know. So you don't have to talk to them about hippocampal neurogenesis, right? But you can say there's enough evidence today that we can say that when you learn new skills, when you practice them daily, you are changing your brain. You are wiring your brain for recovery because what it has done is it had found that this worked for you, but that's what you're trying to change. And now we're trying to change it differently. That is so exciting. So what are the goals? So when you're doing skills work, what are the skills? We want behaviors that are going to interfere with recovery to reduce. So what are those behaviors? If we're talking about on the treatment plan again, what is in the moment going to change your patient's ability to recover? Not a relapse prevention plan all the way down the road, but like I'm avoiding my family. I keep showing up to the nurse's station. I don't go to group. I am about to punch people in the face, right? So any of the behaviors I isolate any behaviors that are going to get in the way of their recovery from whatever it is that they're recovering for, we want to reduce them. Those should be the ones that are happening in your treatment space, wherever you are in treatment. And how are we going to do that? We are going to increase skills using evidence-based practices. And then we are going to measure the efficacy. This is very different than just talking about how you feel. That doesn't mean that that doesn't have importance, but it doesn't change behaviors. You can feel validated and not improve, but you can improve and feel validated. Those two things can happen together. So why focus in on the skills rather than the process? Because it's action oriented. Because skills should be used while in treatment and they should be practicing them every day. Because I just told you what happens when you learn something new and you practice it every day. You change your brain. If I take Spanish once a week and every time I go and I take a class, they teach me something, a different language, or they even forgot that they were teaching me Spanish. I'm not learning it. I need to learn the same thing all the time. This is what learning is based in. And we keep treating this chronic illness of the brain as if it's still moral, even though we know it. We're like, we know that this isn't a moral decision. But if you're just talking them through and they're not learning something new, despite all of these other things that we see, like learning has to take place. If I have diabetes, I need to take my medication. I need to understand that I have to be able to exercise. I need to understand that. I need to be able to engage in healthy eating. I need to understand that. That's actionable. Just talking about how sad I am that I have diabetes isn't going to change my diabetes. That doesn't mean that I don't need a place to talk about it, but it's not going to improve my diabetes. Processing can be dysregulating. So for a lot of our patients, particularly depending on where they are in the treatment continuum, it's too dysregulating. So in an inpatient, you want to process somebody's trauma. That is too dysregulating in an inpatient level of care where an individual has already told us what their coping skill is when they get highly distressed because they're in an inpatient. I'm not trying to get them more dysregulated. I'm trying to give them the possibility that they can engage in some things to be able to manage and sustain their recovery. And processing is too dysregulating. Sometimes we've heard our patients say that, right? And this is another place where we have to be humble. Because sometimes we hear our patients saying, this is too much for me. And we're like, well, they're being avoidant. And you're like, they're telling you it's too much. They were just using a substance 6 days ago. They were just engaging in self-harm. They were just so profoundly depressed they couldn't get up out of the bed. They're telling you it's too much. That's not untrue. They don't have the skills yet to get themselves re-regulated. And that too much too soon can be overwhelming for them. And action goals are not mood dependent. So I'm not constantly addressing the crisis. So when we know what we're doing, we're constantly working on the skills that they need to be able to manage some of the behaviors that we've tracked. If you're running group, the reason why standardization is more beneficial is because when you don't, oftentimes what happens is the most dysregulated person that walks into group typically creates the environment of the group. This is why you'll hear clinicians say it all the time. Oh my God, my group was so hard. Everybody was triggered. Everybody was off. I'm like, because that's what happens, right? Trauma triggers trauma. So when somebody's highly dysregulated, they will trigger the rest of them. That's why you're not supposed to process, right? If I just got into group and I've just been in treatment 3 days and somebody's been at 28 days and I have history of trauma, I am not in a place to be able to hear somebody else's trauma. I might think I am, but keep in mind, sometimes we want something that's not good for us because we've been taught that in order to get well, you need to process your trauma. That's not true. There's no trauma professional that says that that's true. So skills building improves outcomes. So again, skills building addresses capability challenges. It increases the ability to learn new skills, and it helps to support the importance of a full continuum where more in-depth work can be done. So if a patient's like, I really do want to resolve some of these things, I have couples issues that I want to work on, you're like, that's fantastic. I love that journey for you. That's why we recommend the full continuum. Because in here, we got to just make sure that you're safe and you have the ability to engage in skills that are going to allow for you to sustain your recovery. As you continue to navigate that recovery journey through the continuum, you get to work through more and more. It's the same thing as like physical therapy. You break a bone, we treat it, then we send you to physical therapy, and your physical therapy continues on, and you are able to do more and more work based on the length of your treatment. Things that can interfere with capability, a lack of skill. So when a patient's not doing well and we go, I don't know why that patient's not doing well. If they don't have any skills, what are they replacing it with? Us just putting them on a support plan or a behavior contract. We've all seen that. It doesn't work, right? If consequences were enough, we wouldn't have prison systems, right? So that doesn't work because a patient doesn't know how to do it differently unless somebody helps them to understand how to do it differently. And then we measure, does it work? That helps, right? High emotion. So here's a crazy thing. When we increase the likelihood of a patient processing feelings that are too much too soon, high emotion gets in the way of a patient's capabilities. So why would we want to put intentionally that patient in a very high emotional state? It's going to undermine their ability to engage in their skills. Right? So that's the whole brain idea, right? Which part of the brain are they in, which brain state? But that piece is critically important. High emotions prevent our patients from engaging in things that are going to help their recovery. So we need to give them the skills to get themselves out of that. That would be that window of tolerance again. Thoughts, I can't do this, nothing will change, I shouldn't have to do this. I tell patients all the time, as soon as you hear yourself saying that, know you're already in the limbic system. You're already too emotional. So I actually don't need you to challenge any of those thoughts. I just want you to regulate yourself. And then I might be able to measure, like, so if these are the thoughts, those are kind of depressing thoughts, right? That's like somebody giving up hope. So then I'm going to measure it. I'm going to be like, yeah, look it. You're struggling with that depression. So like that we want to work on. So when you say these thoughts, I don't need you to challenge them. Leave them. You can notice them, but I want you to recognize that it's a sign that you got to put out some skills. You got to do some regulation to get those thoughts out, right? Because your cortex is trying to tell you something that it's just not working. Failure to generalize across contexts. So this is probably one of the biggest flaws of behavioral health is that our patients know how to use their skills with us, but not at home. So they are skillful in group or they're skillful in the treatment center. And we know this too because we hear every family member like, they always do well in treatment. We're terrified when they come home because the skills that they learned we became part of their skills. And we actually need them to be able to utilize those skills there. Willfulness and then contingency, right? So do we have new behaviors that they can replace them with? That's that whole hippocampal neurogenesis. So what does coaching sound like? So reinforcing understanding of the action of the skill. Again, and I say this, These are just my suggestions, right? So these are just suggestions that if I was going to be moving towards this, which I hope that you think about, right? I hope that you take some moments and say, like, could I try this? Could I start practicing some of this today? Right? Helping the patient understand why you're doing this is going to be critically important. So where might you be able to use this today while still in treatment? So if I'm providing them a new skill, I might say, tell me where you could use this, right? Where could this help? So if I have a patient that we always say, you hear individuals are saying like, oh, that patient self-sabotages, right? I'm very particular about wording, right? Wording matters. And so self-sabotaging, that's like a tough one because you're like, as a patient, you're like, oh my God, I self-sabotage. Like, that's terrible. You hear patients saying like they're afraid of themselves. They're not self-sabotaging. Their anxiety probably went up, right? They got some anxiety that they don't know. And so they engage in behaviors, which were the behaviors associated with the high level of anxiety before they came into treatment. The fact that they weren't engaging in these behaviors at a certain time means that they were likely actively engaging in skills, but they don't know it if we're not tying it to it. Or just the mere fact of them feeling connected and heard and validated was enough to calm their limbic system so that they could just do their day to day. So I'm going to tie that skill. Tell me where you think you could use this. But they need to have practiced it to ensure that it worked for them, right? So identify if there is buy-in for the new skill. Are you willing to try it? So this goes a little bit to like the assessments. Are we willing to try it? If we don't love it, we can adjust it. But let's give this a shot. And if they don't try it, I'm not angry at them. I'm like, what's going on? That this is a struggle for you, right? What could prevent you from trying it? So if they're in an inpatient, you can enlist peers, right? You can enlist staff, you can enlist, right? But I'm curious about that. What do you think could get in the way for you? For a patient that says that they're not doing aftercare, I'm 100% asking that question. What do you think's getting in the way? Because we keep telling you, like, I trust you want recovery because this is hard work, but we keep telling you, like, an aftercare plan is going to be critically important and you're struggling to show up. Like, what's getting in the way? Are you willing to try this? Let's start doing this before we get you ready for discharge, and then let's do this when you get discharged. Are you willing to try that? And then how do you think the skill could help build your recovery? Using real life examples. They're real life examples. So you've been in treatment 3 times. Each time this has happened, this would be a place so we can monitor it, right? We can measure your anxiety and your depression and see what's going on with that, right? Your trauma, whatever it is that you're measuring. Let's see if this changes this for you. And then I'm going to go back. Are you willing to try this? Informing patients. Skills are concrete tools that we can use every day. I tell every patient that I've ever worked with, I can't be a skill. I'm not transferable. So when you say things like, you're the only person I trust, we have to actively work on like what that means for you. Right? So it means that when you have high levels of anxiety and then you come to see me, I'm able to help you to get regulated. So we got to use that to start building that for you. Right? Safety is paramount for people to be able to do the work. So it means that I'm providing safety. It means that you're all providing safety, which again is critical, but these are the steps to be able to do the next one. That they have to learn and practice new skills. That's the part of the brain that we have to help them to understand. You've got to learn and practice them. That's how the brain rewires. That's how the brain changes. Right? So we're not going to process high emotions because it's going to interfere with your ability to do these skills. And one day, if you decide that you want to talk and work through some of those high emotions, you can. That's the full continuum. But I want you to also hear, if you don't feel like you've resolved your trauma, but you've learned how to manage it, that is also recovery. Changing the stories that we're telling our patients. Right? So we're going to use this group to support goals, to support your skill development so that you can practice it today and we can talk about what works. And then there is homework because that's how learning takes place. If you don't practice something, then you don't learn it. That's it. So the way that I always like to say it is that we can't be the gatekeeper of recovery. So when I'm doing a different group than somebody else is doing, then somebody else is doing, then somebody else is doing, and nobody else knows what the patients are learning other than the person that's facilitating the group, then I am the gatekeeper because nobody can help to reinforce the behaviors that the patients are trying to learn. That's why they end up thinking they need me. So clinical implications, changing the way we provide our treatment, that this is an example, right? So I'm going to cover this slide and one more, and then I will pause for any last minute questions. Patient A has alcohol use disorder primary and has been in treatment 3 weeks and struggles with anxiety, which has contributed to his use. Most of our patients are comfortable saying that. Patient reports high anxiety has been a trigger for him in the past. GAD-7 score was 18 upon admission, 15 the following week, and then it went back up to 17. He was seen at nursing the last 3 days reporting he can't sleep. Additionally, he thinks this started after his first family phone call, and now he's threatening to leave treatment. How do we use measure-based care to drive intervention? So I'm going to very quickly just give you like a little bit of a nut, right? Like, so here's our patients. This is an average patient. Replace any of the behaviors, right? Where I go, listen, here's some of the skills. I'm going to use the scores. Your anxiety is still pretty high. That makes sense. The fact that you're sleeping is being impacted suggests that that anxiety is getting worse. So here's what we can do, and I'm going to measure it. We're going to get you with nursing because that sleep, man, that's an important one, right? I'm not even talking to him about why he's trying to leave treatment. I am literally just trying to help him to realize we can help you feel better today. We're going to get you some skills to get regulated. I'm going to get you with nursing though, because that's sleeping. Man, I am grumpy as hell if I don't get a good night's sleep. 3 nights of a bad night's sleep, woo, we're going to treat that. That's going to get in your way because that's what they're looking for. They just want to feel better and they want to know that there's something triggered. I'm not going to just say, why are you going to leave treatment? You can't leave treatment because now I'm like, I was already anxious and now it's like too much. No, we're going to help you feel better. And these are the things. And we're going to measure it because we're going to make sure that you feel better when we do. That's the difference. Documentation, I'm not going to cover that, right? You can figure out how to document it in your own, but it's important. That's a really great one for UR. So here are the overall benefits. Clinical outcomes. So if you are tracking outcomes, clinical outcomes are for us. They are critically important. Measured-based care is going to give you those clinical outcomes, but it's also going to give the patient the tools that they need to be able to manage their recovery. That's the difference. So measure-based care will always help to improve your outcomes because it's literally driving your interventions. And when something doesn't work, you're able to adjust to help that patient. If you are working with value-based contracting, this is going to help you also to be able to speak to the work that you are doing and review the outcomes and the patient in the direct care. So that is going to be another critical component. Value-based contracting is that payers are saying, listen, you guys have to prove that what you're doing is working. And it can't just be that you're saying they're better than when they came to you and they came to you in a crisis. You got to do better than that. And honestly, I can't say that that's wrong because that is our ultimate goal. We want our patients to get better long term. The Joint Commission, documentation and treatment planning streamlined for efficiency. So it aligns to the Joint Commission standings, CARF. Professional development. The beauty of this also is that it professionally develops your staff. Because when it's standardized, if one therapist is struggling, then you actually can train them up so that everybody has a feeling of competence. If somebody has 15 years of experience and somebody is brand new, I can't generate the gap, but I can use this information to train up that newer therapist so that they feel just as competent as somebody that's been 15 years in the treatment space. And from a patient perspective, I feel like I've got just the same treatment as anybody else, right? And staff engagement. So the workflow is easier and more precise, providing them time to do their work because we are streamlining and we're not reinforcing the crisis. So with that, I'm going to say thank you. I will look and see if there's any questions. I know we have 1 minute for any questions. If I don't get to it, I'm certainly happy to answer that later if you want to circle. But I hope today what you did is walk away with just a thought of maybe I'm going to start measuring the treatment for my patients. And maybe I'm going to use this to drive the interventions because ultimately we're all invested in the same thing. Patients' long-term, meaningful, sustainable recovery. So thank you. Thank you. If I did not answer any questions, and please feel free to email me or Callie, and we will get to those questions. And I look forward to hoping to see you at the Power of Families in Connection and Recovery with Wendy next month. Have a wonderful weekend, everybody, and a wonderful holiday. Or for those of you that aren't looking forward to it, just a holiday.